a teaching session on ARDS. As you all know that it's a very vast topic, and my apologies in advance if I have skipped a few topics in ARDS. We can have another class, where we can cover everything. So I tried to cover as much as possible. So to begin with, what is the journey of ARDS? Now, this is the timeline of ARDS criteria with some future directions. So previous criteria of ARDS was published initially in 1994, which was by American European Consensus definition. So it said that the timing of ARDS is acute, but it was not specified what is acute. Then chest imaging showed bilateral infiltrates on chest radiograph. Oxygenation, they said that, they divided it into acute lung injury and ARDS. ALI being PF ratio being less than 300 and ARDS PF ratio being less than 200. PEEP was not specified. They said origin of edema is respiratory rather than cardiac. So the pulmonary artery wedge pressure is less than 17. And this was the previous definition. Now we are using the current Berlin definition of ARDS, which came in 2012, which specified the timing within 7 days, and chest X-ray showing bilateral infiltrates or CT showing bilateral infiltrates. And they defined the PF ratio using PF ratio, the severity of ARDS as mild, moderate, and severe, and PEEP of minimum 5, and origin of edema not fully explained by cardiac failure. Now, some short-term possible revisions that CT will also include ultrasound. I mean, the chest imaging will also include ultrasound, and oxygenation targets or oxygenation. You can look at the SpO2 FiO2 ratio also along with the PF ratio, and you can include high flow nasal cannula or no requirement for minimal PEEP also into the definition. So these are some future revisions possible into 2022 and later. So now what are the causes of ARDS? Usually they're divided into direct causes and indirect causes. So direct are the pulmonary causes and indirect are the extrapulmonary causes. So we all know about this, pneumonia being the most common cause of ARDS, viral, bacterial, fungal, all of them. Pulmonary contusion secondary to road traffic accidents or aspiration of gastric contents or inhalational injury, near drowning causing direct pulmonary injury. And there are a lot of indirect causes of ARDS also. Non-pulmonary sepsis, acute pancreatitis, drug toxicity, all these are the indirect causes of ARDS. Now, similarly, now the most common cause is pneumonia, and these are all are minor contributors. The second most common is sepsis, and aspiration comes third. So these are the most common causes of ARDS, published in NEJM 2004. Now, little bit about pathophysiology. So as you can see, this is a Norman alveolar capillary membrane, and this prevents the development of alveolar edema. Now, what happens when this alveolar capillary membrane breaks? So if there is mild injury, there will be mild edema formation. The tight junctions here will be disrupted. There will be decreased surfactant production. There will be mild glycocalyx shedding, activated epithelial cells secreting chemokines and expressing adhesion molecules. Severe injury, severe edema, severe disruption of tight junctions, and the capillary membrane barrier becomes more permeable, leading to alveolar edema. So this is the pathophysiology of ARDS. Now, how these mechanisms actually affect? When there is alveolar capillary barrier injury with interstitial and alveolar edema, what it leads to is, it leads to decreased pulmonary compliance and increased work of breathing. Similarly, when there is diffuse alveolar filling, that is alveolar edema, because of this breakage, then VQ mismatch happens and shunting happens. And what do you find clinically? Severe hypoxemia with diffuse bilateral radiological opacities. When there is surfactant inactivation and decreased production, there is end expiratory alveolar collapse and favorable response to PEEP is found. Platelet endothelial activation with lung microvascular thrombosis and all this. There is increase in dead space ventilation, pulmonary artery hypertension. And the leak of lung inflammatory mediators into the systemic circulation will lead to SIRS and multi-organ dysfunction. Now, this is how the pathophysiology causes these kind of physiological and clinical findings. Now, these are some differential diagnoses of ARDS. This can mimic ARDS, but they're not actually ARDS. Congestive cardiac failure, interstitial lung disease, connective tissue disorders, drug-induced damage, and all that. Now, just last slide on pathophysiology, then we'll move to management. So ARDS is actually divided into 3 phases. The first 3 days, 7 days is the exudative phase. Then comes the proliferative phase for 3 weeks, and then the fibrotic phase after 3 to 4 weeks. Now, management of ARDS. Now, this is just a brief introduction before we go into the detail of these therapy. So, standard of care is your low tidal volume ventilation, high PEEP, looking at the plateau pressures, driving pressures, plateau pressure being less than 27 or less than 30, driving pressure, that is plateau pressure minus PEEP, less than 13, transpulmonary pressure. So the pleural pressure you calculate by estimating the esophageal pressure. We'll discuss that in detail. And then mechanical power, which is representing the combination of several ventilatory parameters, but the role of each component in lung damage requires further studies. This is the standard of care. Rescue strategies is prone positioning, recruitment maneuvers, neuromuscular blockage, inhaled vasodilators, and ECMO. So we'll talk about all this in detail. Now, this is, I really like this flowchart, which was given in critical care med in 2017. Optimal strategies of severe ARDS, starting from mild, moderate to severe, how they have increased the treatment. So starting with NIV, low to moderate PEEP, low tidal volume ventilation. As the severity of ARDS increases, you increase the PEEP, paralyze the patient, go for prone positioning. HFO, we are not going to discuss because not much evidence for that, and we are not using it also. ECOR, and finally ECMO. So this is your stepwise approach to improve. The interventions which you can do as the severity of ARDS increases. So role of NIV, is there any role of NIV? So NIV, there is some role in mild ARDS. So this is basically the article which came in Intensive Care Med in 2016, which said that if it's mild ARDS, you can use high flow nasal cannula, evaluate after 1 hour. If failure to improve, or if there is moderate respiratory distress, go for NIV, evaluate after 1 hour. But if any of this following is present, that the patient is becoming hemodynamically unstable, or patient is going into altered sensorium because of hypoxia or hypercapnia, failure to improve the PF ratio, or there is severe respiratory distress, go for endotracheal intubation. If improvement, then you can continue NIV. So the role of NIV is there in mild to moderate ARDS only. And if the PF ratio is more than 300 and no respiratory distress, you can just follow a standard oxygen therapy. But if any of this is present, like we discussed, if the patient is hemodynamically unstable, having acute renal failure, reduced level of consciousness, PF ratio is low, there is severe ARDS, go for endotracheal intubation. If any of the following is present, like hemodynamic instability, deterioration of neurological status, worsening of hypoxemia, do not wait, go for intubation. Now, mechanical ventilation in ARDS, when you intubate the patient, what is the issue? So you need to do lung protection. What do you do even if you do lung protection, the hypoxemia becomes critical and refractory? What are the salvage therapy? Which therapy will be best for your patient? And what is the role of ECMO? So this is what we're going to discuss today. Now, let's go at the concept of baby lung. Now, what is baby lung? Now, ARDS lung is called baby lung. Why is it called baby lung? Because ARDS lung has normal tissue also and unaerated, partially aerated alveolar also. So normal segments will inflate easily, but the unaerated segment will actually distend poorly, leading to high pressure and low response. And normal lungs may become overinflated when you're using the traditional tidal volumes, right? So there's only little part of the lung which is left, which is actually normal, rest of the lung is gone. And if you use traditional tidal volume for inflating that small part of the lung, that lung will become overinflamed. So that is why we need to adjust our tidal volume to suit this baby lung. So mechanical ventilation and ARDS are associated with a lot of injuries, including overdistension, stretch, shear, causing ventilator-associated lung injuries. So how do we actually deal with it? Now, these are the problems of ARDS. stretch of the overdistended compliant alveoli, leading to volutrauma, high inspiratory pressures, leading to barotrauma, shear stress due to complete closure and reopening of non-compliant alveoli, that is atelectotrauma, and release of inflammatory mediators from the lung, that's called biotrauma, all this leading to ventilator-associated lung injury. Okay, so this is a nice article by Slutsky and Ranieri in 2013 NEJM, which has described all these problems which I just listed beautifully in a diagram, and they have explained it quite well also. It's a good reference for all the exam goers. They should read this article. So how ventilator-associated lung injury can cause atelectotrauma, air leaks, overdistension, barotrauma, and eventually all this will lead to biological alterations only, like by releasing the inflammatory mediators, which will have systematic effect, and the patient will go into multi-organ dysfunction. So very nice article for you to read. Now, ventilatory strategies in ARDS. So what are we trying to achieve? You need adequate ventilation of the compliant alveoli without causing volutrauma and without causing barotrauma. So what is your strategy? Your strategy is using small lung protector, low tidal volume, 4 to 6 ml per kg, high respiratory rate, permissive hypercapnia, limiting plateau pressure less than 30, or you can consider using pressure control ventilation, or PRVC, though there is no evidence that shows that one mode is better than the other mode. So now, what is the purpose behind lung protective ventilation strategy? So we are trying to keep ourselves in this safe zone. Target tidal volume of 6 ml per kg. Below this, if you go, then because of repetitive opening and closure of alveoli, there will be a lot of atelectotrauma. And above this, if we go, then because of alveolar distension, there will be a lot of volutrauma and barotrauma. So we are trying to keep in this safe zone. Now, a lot of evidence, we all know the famous ARMA trial in 2000, which said that lower tidal volume as compared to traditional tidal volumes for acute respiratory distress syndrome did have mortality benefit. So we all know the protocol. I need not go through this in detail. They use 6 ml per kg versus 12 ml per kg. Plateau pressure target was less than 30. Here the target is more than 50. PEEP according to the PEEP FiO2 table, which we still use in bedside. So, any newcomer is coming to your ICU, a new DNB student, we give them, we still ask them to follow the PEEP FiO2 table to begin with, when they start treating these patients with ARDS. So actual PEEP of 8, and the result was there was a significant difference in mortality when we used lung protective ventilation strategy. So this was the intervention group mortality was 31%, the control group was 39.8%, p-value being significant. So other benefits were that lower duration of mechanical ventilation and lower incidence of non-lung organ failure days. So 6 ml per kg, not only that, there were a lot of other trials also. Cochrane database and ARDS network trial, Amato did a lot of study before that. So 6 ml per kg is the standard of care now. Now, what is the protocol of lung protective ventilation? Now, this is very important for all the nurses who are here and all the beginners who are here. How do you actually calculate the predicted body weight? Now, do not use the total body weight to calculate 6 ml per kg. You have to use the predicted body weight. Now, this is the formula. You use the height rather than the weight, isn't it? So the predicted body weight will be, in males, will be equal to 50 plus 2.3 into height in inches minus 60. And for females, it is 45.5 plus 2.53 into height in inches minus 60. And initial tidal volume, usually you set at 6 ml per kg, add a PEEP of 5, select the lowest FiO2 that is required to achieve SpO2 of 88 to 95%. Reduce the tidal volume by 1 ml per kg every 2 hours until the tidal volume is less than 6 ml per kg. VT of 6 ml per kg, measure the plateau pressure. And if the plateau pressure is more than 30, decrease by 1 ml per kg until it is less than 30. And you can go as low as 4 ml per kg of tidal volume. Then you monitor the ABG for respiratory acidosis. If the pH is 7.15 to 7.3, increase the respiratory rate till the pH is more than 7.3 and respiratory rate less than 35. If the pH is less than 7.15, increase to 35. And if it is still less than 7.15, then increase the VT in 1 ml per kg until the pH is more than 7.15. And optimum goals is the tidal volume is 6 ml per kg of predicted body weight, not total body weight. Then a plateau pressure less than 30, saturation target of 88 to 92, pH of 7.3, and PO2 of 55 to 80. So this is for beginners. The table is very, very important. When you start treating a patient of ARDS, try to use this table, and the more and more you use this, you'll remember this also. Now, what are the consequences of lung protective ventilation? Now, everything was good with lung protective ventilation, but there were some problems like, the tidal volume factors into minute ventilation, and that determines CO2 removal. So naturally, when you're using low tidal volume ventilation, that affects your CO2 removal. Tidal volume also determines the degree of lung inflation and recruitment of the atelectatic lung. So there is a chance that very low tidal volume can cause lung collapse as well. So adequate tidal volumes are important to ensure the patient is also comfortable, and there is a decrease in sedation requirement also. So low tidal volume does work well in ARDS patient. It prevents volutrauma and improves survival. However, its disadvantages are that it causes hypercapnia and higher level of sedation, right? So these are the consequences of lung protective ventilation. Now, what are the rescue therapies? We won't actually call it the rescue therapy, but what are the first line therapies for hypoxemia after lung protective ventilation? So PEEP, recruitment maneuvers, paralysis, prone ventilation, inhaled nitric oxide or inhaled pulmonary vasodilators, APRV and ECMO. So we're going to talk about each and every of this in detail. Now, what is PEEP and why do we give PEEP? So basically, your alveoli is collapsed. To open up the alveoli, you give PEEP. As simple as that, isn't it? So it opens up your alveoli. Now, how do you decide which is the right PEEP? So let's go a little bit about physiological basis of PEEP. Why do we give PEEP? It prevents the shear stress resulting from cyclic opening and closing of alveoli. It reduces intrapulmonary shunt and improves oxygenation. It reduces dynamic tidal strain and stress applied to the lung. It reduces mechanical stress that results from local inhomogeneities in the lung. Now, how do you decide PEEP? So a lot of articles have actually come. They have told these 10 ways of deciding PEEP. So you have a lot of options, but choose what is best for your setup. So a lot of people arbitrarily set up a high PEEP of 15 to 20 and then slowly come down. Use of ARDS in a table. Most of the people in ICU still use this ARDS in a table. You can titrate PEEP according to maximum compliance. That is the PEEP at which highest static compliance is there. And this has the advantage of being tailored to each specific patient. Set the PEEP slightly above the lower inflection point. This is very important of pressure volume curve, therefore avoiding cyclical atelectasis. Use staircase recruitment maneuver to find the lowest PEEP at maximum oxygenation is maintained and set that as your PEEP. Titrate PEEP to achieve the smallest intrapulmonary shunt if you have a PA catheter in place with continuous SpO2 monitoring. Titrate PEEP to achieve lowest arterial minus end-tidal CO2, that is PEEP at which the dead space is minimal. Use transpulmonary pressure calculated from esophageal balloon manometry using esophageal pressure as surrogate to pleural pressure. Adjust PEEP so that the transpulmonary pressure at end expiration is 0 to 10. Use electrical impedance tomography, titrate PEEP to achieve highest electrical impedance in thorax. That is greatest amount of aerated lung. And you can use sequential CT scans also. So there are a lot of methods to titrate PEEP. Now finding the lower inflection point. We'll talk a little bit about that. So how do you actually find the lower inflection point? So what is lower inflection point and how do you actually find it? So basically the thing is that, So you can find this on the pressure volume curve, and above the upper inflection point, there will be regional overdistension, and below the lower inflection point, there will be alveolar collapse. So the minimum pressure that is required for alveolar equipment is the lower inflection point, and you can decide this and keep the PEEP above the lower inflection point. Now, what is a staircase or recruitment maneuver or de-recruitment maneuvers? So recruitment maneuver will increase the oxygen saturation. You do a recruitment maneuver and then you do stepwise decrease in PEEP while watching the saturation. Drop in saturation at one point of time will cause de-recruitment and just go at the level of PEEP that is above that. So optimum open lung level of PEEP is here. So this is a very nice diagram to show. You have done a recruitment maneuver, then you slowly reduce your PEEP. You notice that at this PEEP, the desaturation is happening. So just go at a level above that. This is how this is the staircase recruitment maneuver for deciding what is the optimum PEEP. Now, this was a very nice article that was actually published in JAMA recently in 2019. The question which was addressed is, what is the clinical benefit of titrating PEEP according to lung mechanics versus an empirical high PEEP FiO2 strategy in patients with ARDS? And the conclusion actually showed that there was no difference in the outcome and mechanical ventilation free days in moderate to severe ARDS patients. So if you use the transpulmonary approach also to guide PEEP or the traditional high PEEP FiO2 table, they did not find any difference between the two groups when it came to the mortality benefit or disease days free from mechanical ventilation in moderate to severe ARDS. Now, what exactly is this open lung approach? So what is open lung? You use transiently high transpulmonary pressure to reopen the lung units, followed by sufficient PEEP to maintain them opened. Use a recruitment maneuver to open the lung units and followed by high PEEP to keep them open. That's all is an open lung approach. So these are the different trials which had come so far, which actually studied high PEEP versus low PEEP in moderate to severe ARDS. Initially came the Alvely trial in 2004, then the Loves trial, then the Express trial. So summarizing all these trials, all of them basically say the same thing, that there was no difference in mortality, there were no difference in ventilator-free days. But what actually difference they saw is that the intervention arm had lower refractory hypoxia and lesser need for rescue therapy. So all these trials have actually, again and again showed the same thing, that there's no mortality benefit of using high PEEP. There is no reduction in ventilator days by using high PEEP, but there is lower refractory hypoxia and lesser need for rescue therapy. Then came the RELAX trial. What is the optimum PEEP in patients without ARDS? So in RELAX trial, basically, in ICU patient who receive invasive ventilation for reasons other than ARDS, did PEEP this lower PEEP non-inferior to higher PEEP at day 28. And what they actually found was, in this clinical trial, among patients receiving invasive mechanical ventilation, a strategy of lower PEEP was non-inferior to the strategy of higher PEEP in patients without ARDS. So that was a RELAX trial, which said that higher PEEP, lower PEEP doesn't matter if the patient doesn't have ARDS. Now, we'll come to recruitment maneuvers. Now, what is recruitment maneuver? Recruitment maneuver is basically a maneuver which you do to open up the closed non-compliant alveoli. And it has a potential, please remember, it has a potential only in early phase of ARDS. So what are the strategies which we use here? You can use 30 to 40 centimeters of CPAP for 30 to 40 seconds. You can use serial large tidal volumes for 1 to 2 minutes. Series of breaths with pressure control ventilation, CT scan method or ultrasound method to recruit. Now, just safety wise for all the students and nurses, before you advise anybody recruitment maneuver, make sure that the patient is hemodynamically stable. Check for pneumothorax or pneumomediastinum. Check saturation to PO2 ratio, EtCO2 to PCO2 ratio. Check the compliance. Check if the patient is adequately sedated and adequately, a neuromuscular blockage is given, and do an ABG. So recruitment maneuver also, there have been a lot of meta-analysis and systematic reviews discussing recruitment maneuvers. And all these actually found the same thing, that there was significant increase in oxygenation and fewer side effects with using recruitment maneuvers, but none of them did translate into mortality benefit. So basically what you're trying to avoid is avoiding over-distension and avoiding de-recruitment and atelectasis. So trying to be in the safer window. So this is the effect of recruitment on CT scan. If the lung is recruitable, definitely they will see an improvement. So this is what we do in our patients when you take them for a CT scan. Do a CT scan at a PEEP of 5, then increase the PEEP and pressure support and inspiratory pressure, and then see what is the change in the CT scan. And if you ask your radiologist to report it also, they'll report this, that if the lungs are recruitable or not, seen on the CT scan. Now, what is transpulmonary pressure in ARDS? So, transpulmonary pressure is basically you have to measure the esophageal pressure to find out the transpulmonary pressure, and which is a reasonable surrogate for pleural pressure. Transpulmonary pressure excludes the effect of chest wall compliance on respiratory mechanisms. It can be used to guide the PEEP and tidal volume setting, and it may help in reducing the incidence of ventilator-induced lung injury. So your end expiratory pleural pressure can be used to set up the PEEP, and the end inspiratory pleural pressure can be used to set up the inspiratory safe P-plat, and driving pleural pressure can be used to set up the tidal volume. So, but there are some problems with the transpulmonary pressure measurement also. Like, esophageal manometry is used to measure the esophageal pressure, which is a surrogate for pleural pressure. So that can be affected by elastic recall of esophagus muscle tone, transmitted pressure from the mediastinal structures, the posture of the patient, position relative to the lung, esophageal balloon size and filling volume. It is prone to error also because of malposition and various assumptions that have been made. That is, the pleural pressure is equal throughout the chest. There are a lot of alternatives like de-recruitment maneuvers to find out the optimum P, which can arrive in the same location, a same conclusion without using esophageal manometry. So now coming to neuromuscular blockage in ARDS. So there have been two landmark trials which one is NEJM to 2010, the Accuracy trial, and recently the ROSE trial which has come up, which has evaluated the effect of neuromuscular blockage in early ARDS. So Accuracy trial came in 2010, 340 patients of ARDS within 48 hours, PF ratio less than 150. 90-day mortality was 31 versus 40, so significant. More ventilator-free time, less organ failure, muscle weaknesses were similar, may work by facilitating lung protective ventilation. Cis atracurium paralysis did improve survival in ARDS. That was the conclusion. Now, but after that, ROSE trial came very recently, which also studied about early neuromuscular blockers in ARDS, but it did not show any significant difference in mortality at 90 days between the patient who received an early and continuous cis-atracurium infusion and those who were treated with usual care approach with lighter sedation strategies. Now, what are the difference between the two trials? So, Accuracy trial was done in Europe and ROSE was done in US. If you see the number of patients, ROSE trial had more number of patients. This was double-blinded, this was unblinded. Accuracy trial used the American European consensus definition, whereas ROSE trial used the Berlin definition because it came only in 2012 and this was done in 2010. And this was the criteria for moderate ARDS, which was similar. And mean time for ARDS diagnosis to trial was 16 versus 8 hours. And they both used cis-atracurium. They both used lung protective ventilation strategies, though this used a higher PEEP ROSE trial. And so basically, they did not find any difference in ICU-acquired paresis and long-term outcomes between the two groups. And the serious adverse events also, pneumothorax was more frequent in the control group, but here also the rate of barotrauma did not differ. Now, why did ROSE trial not show any benefit? Prone position was used less in ROSE trial. No optimization of mechanical ventilation and sedation prior for entry to ROSE. Patients recruited early phase of illness in ROSE trial. Increased PPUs in ROSE trial, patients more likely to respond when not entered, increased sedation in the control arm in Accuracy trial, or it could be just chance alone. So, but our standard of practice is still to use early neuromuscular blockage in early ARDS if there is any a ventilator patient dyspnea, and if the patient has not been able to manage with just deep sedation. Now, next, coming to prone position, the most talked about topic in ARDS. How does it work? It improves oxygenation. It allows ventilation at lower tidal volume. It helps in drainage of secretions. But there are problems with that also. It causes pressure ulcers, lines, tubes, difficult to manage, CPR difficult to do, and 20% of patients are non-responders. Now, the biggest advocate is Gattinoni. He has been talking about prone position for ages. So what is basically prone position? Proning is also a kind of recruitment maneuver only because it's a great equalizer. It homogenizes the chest wall compliance. It makes the VQ matching better. It decreases the deforming forces of abdominal pincers and heart. So basically, it is beneficial in a lot of ways. Now, this is how it works. Now, if you see, it improves the VQ matching, it recruits the compressed lung units, it improves the hemodynamics. Now, this is how the prone position works. CT scan effects of proning, improved aeration of lung. So because the effect of abdominal pincers and all is gone, there is more homogenization, there is less VQ matching, there is more ventilation in the compressed lung units which were compressed earlier. That is why there is improved aeration in the lungs. Now, summary of various trials. There have been numerous trials about proning. We have been talking about proning since a long time, since the last 23 years. So Gattinoni in 2001, followed by a lot of people. So, but the actual mortality benefit or the actual landmark trial which showed proning as a game changer was PROSEVA trial. So PROSEVA trial being the king of all prone trials. So what was the question that was addressed? Does early proning for more than 16 hours a day reduce 28-day mortality among patients with severe ARDS? And who was excluded? Raised ICP, massive hemoptysis. These are actually some contraindications to proning. So this PROSEVA is a good read for proning. Everybody should read PROSEVA, including the nurses and the DNB students. Everybody working in ICU should read the supplementary material of PROSEVA trial. So what was excluded? ICP more than 30, massive hemoptysis, recent tracheal surgeries, sternotomies, DVTs, ECMO. So all these are the patients who were excluded. And what stats you should know? Proning is associated with more uniform distribution of tidal volume, challenges the concept that the gravity is the only dependent factor for ventilation and perfusion. Analysis of this data suggests that improvement in mortality are not from improvement in oxygenation, but likely reduction in the incidence of ventilator-induced lung injury. So what is the take-home message of PROSEVA? Proning decreases the mortality in severe ARDS independent of improvement in oxygenation. So proning improves oxygenation by improving VQ matching. The dorsal flow is not entirely dependent on gravity. Edema shifts ventrally. So this was the result, 16 versus 33%, almost a double reduction in mortality with just a simple art of proning. So why did PROSEVA succeed? Because they intervened early, within 36 hours of ARDS. They used the most appropriate patients, 12 to 24 hours of stabilization period, and significant proportion of time spent in proning, 73 versus closer to 30% in other trial. Another very, very important point which I have not written here is all the centers were very, very experienced in proning. So only those centers who have 5 to 10 years experienced in proning were enrolled in PROSEVA trial. So, it takes time to master the art of proning also. So we'll go to the advanced modes of ventilation. What is APRV? APRV, we already had a teaching class, so I'm not going to go into the detail of it. So you can go through the video recording of that class. So APRV, based on open lung concept, it was described in 1987. Basically, it is maintenance of CPAP, allowing spontaneous breathing without significant pressure fluctuation with a brief period of release, allowing for efficient ventilation. So there is high pressure, low pressure. You said there is high and low time, and there is spontaneous breathing that is possible. Please go through the APRB class. Very interesting it was, taken by Monica ma'am. So mandatory breaths are achieved by dropping the high pressures in the circuit briefly to 0 seconds for few seconds, which is the expiratory time. The short expiratory time will prevent the alveolar collapse, however, contributes to air trapping and intentional auto PEEP. Spontaneous breathing occurs only at higher pressure, which causes recruitment. The short expiratory time will help in CO2 elimination. A single pressure helps in oxygenation and ventilation without increasing the plateau pressure and avoiding volutrauma. Now, what are the settings which we use? P high, not more than 30, which is usually equal to the plateau pressure. T high is 4 to 6 seconds. P low is 0. T low is 0 to 0.6 to 0.8 second, 40% of expiratory flow. 90 to 95% of the time, the lungs remains inflated. So just a ventilator graphic of APRV. Now, last slide about APRV. I'm telling you, I'm not going into detail because this class has been already taken. So this was Zhou et al. Study, which was published in 2017. It was an RCT which compared APRV versus lung protective ventilation early ARDS, and they did see mortality benefit with APRV. So this was the only trial which has actually showed mortality benefit with APRV, 19.3 versus 34.3%. Inhaled nitric oxide, inhaled pulmonary vasodilators, I think we have used a lot in COVID. So what is the physiological basis of it working? It improves oxygenation because it decreases pulmonary vascular resistance. It decreases pulmonary edema. It reduces or prevents inflammation. It has some direct antimicrobial effects also, which is very interesting. So it protects against infection also. So basically, this is it minimizes the VQ mismatch owing to pulmonary hypoxic pulmonary vasoconstriction. So it improves oxygenation by improving the pulmonary blood flow. So improves oxygenation, safe to use, maximum benefit when you combine with other strategies. Something about inhaled nitric oxide. In the similar way, other inhaled pulmonary vasodilators also like iloprost also work. Now, mechanical power. What is mechanical power? Let's talk a little bit about that. It was postulated by Gattinoni again, father of ARDS. Ventilator-induced lung injury is caused by delivery of critical amount of mechanical injury to the lung, right? So greater the mechanical injury, greater will be the lung damage. That's common sense. So energy and time are the two essential components of ventilator-associated lung injury development, and together they're used to define the mechanical power. So mechanical power is the amount of energy transferred from mechanical ventilator to the respiratory system per unit of time, and is determined by the combined effect of applied tidal volume, driving pressures, respiratory rate, inspiratory flow, and PEEP, as well as determinants of mechanical properties of the lung. So this is the equation that is used to calculate it. Please don't remember this. But mechanical power is a better driver of lung protective ventilation compared to the individual parameters, as it considers the balance of these parameters as a whole, right? So that is why it is considered to be better. So to summarize about these new age techniques, these novel strategies like driving pressures, mechanical power, they require further evaluation. Strong physiological rationale is definitely there. They sound good, but we need more data on it. And specific strategies and protocol need to be designed and tested in rigorous stepwise manner. Now, a little bit about my favorite topic, ECMO. I've taken a detailed class about it, so I'm not going to go in too much of detail. Just a brief overview of role of ECMO. So proning did not work, and if your candidate is suitable for ECMO and there is no contraindications, you can definitely make a call to an ECMO center to see if they're going to get accepted by them or not. So basically, it's a mechanical circulatory support in which the venous blood is drawn and pumped through the machine and oxygenated via the oxygenator, and the oxygenated blood is reinfused into the separate vein. So that is your VV ECMO for ARDS. Very simple. So take deoxygenated blood, run it through the pump and then membrane, and return oxygenated blood. So what are the indications here? So potentially reversible. This is the key here for using ECMO. Any potentially reversible hypoxemic respiratory failure. These are also the ELSO guidelines, which we use in our clinical practice on day-to-day basis. So potentially reversible hypoxemic respiratory failure with a PF less than 100, despite optimization of the ventilatory settings, including tidal volume, PEEP, and I ratio. Also that, proning you have tried. Hypercapnic respiratory failure with pH less than 7.25, despite optimum conventional mechanical ventilation. And ventilatory support as a bridge to lung transplant or something. So role of VV ECMO in a potentially reversible ARDS definitely is there. So two modern day trials have been done. We all know Caesar and Aeolia. Caesar came in 2009 and Aeolia came in 2018. So what question did they address? Does VV ECMO compared to conventional mechanical ventilation for severe but potentially reversible acute respiratory failure lead to better outcomes? And so in Caesar, patients were randomized to be transported to an ECMO center versus no transport to the ECMO center. So this is actually did not compare the patients who are on ECMO versus not on ECMO. It actually randomized patients to be transported to an ECMO center versus a non-ECMO center. And not all patients randomized to the ECMO center actually received ECMO, because when they went to a center which did ECMO, obviously did a better management of ARDS, they optimized the ventilatory settings better, they proned the patients better, and the outcomes were automatically better. So in earlier trial, lung protective ventilation and prone ventilation was encouraged. So patients with the selection criteria, it was 180 patients here and 249 patients there. So patients with severe but potentially reversible respiratory failure, and here severe ARDS patients, this was the criteria. And if you see the pooled 90-day mortality was 36 versus 48%. So the 90-day treatment failure, death for the ECMO group and death for the crossover patients. So in both the trials, ECMO for in Eolia trial, which is the more latest one, ECMO for severe ARDS. So ECMO for severe ARDS showed no significant benefit of mortality of day 60 as compared to the strategy with conventional mechanical ventilation, which included the crossover patients as well. So Eolia trial did not show a mortality benefit, and it was stopped early for futility as well. And sorry, they also saw more bleeding, more severe thrombocytopenia, and fewer ischemic stroke in the early ECMO group. So possible ECMO configuration in COVID-19 ARDS. Now recently we were swept away by the COVID pandemic. So this is what we saw here. So VV ECMO had a role in pneumonia, ARDS, septic shock, cardiogenic shock, refractory to multi-organ failure, cardiac arrhythmias. There was some role of VVA ECMO. And in patients who had COVID myocarditis and cardiac failure secondary to COVID, there was some role of VA ECMO. And refractory hypoxemia along with this VVA ECMO. So some role of COVID and ECMO. Now, I'm coming to my last slides now. Current and evolving standards of care in ARDS. Now, current standard is ventilatory support in ARDS. Now, we already spoke about lung tidal volume, low tidal volume ventilation, limiting your plateau pressure to less than 30, and PEEP titration to use PEEP FiO2 table. And so newer things in ARDS, try to limit your diving pressure less than, that is plateau pressure minus PEEP, to less than 15. Minimize the delivered mechanical power. Individual titration of PEEP using one of the several methods which we discussed, either the best compliance method, measured recruitability, transpulmonary pressure, or your electrical tomography method. Spontaneous breaths when appropriate, monitor to avoid dysynchrony or large efforts. You can use helmet, NIV or HFO, high flow nasal cannula, in mild to moderate ARDS to avoid intubation. Now, current strategies in ventilatory adjuncts, prone positioning in early moderate to severe ARDS, especially when your PF ratio is less than 150. And other ventilatory adjuvants, neuromuscular blockage should be used when indicated, especially when there is severe dysynchrony, severe hypoxemia, marked increased respiratory drive, and it's difficult to safely ventilate your patient. So there is definitively a role of neuromuscular blockage here. VV ECMO after proning if patient is you're not able to ventilate the patient, and PF ratio less than 80. Pharmacotherapy, now we have the famous recovery trial, which suggests that, early steroids for ARDS with COVID-19, early steroids for other causes also. Conservative fluid strategies for patient who are not in shock, conservative fluid strategies for patient in septic shock also. So these are some evolving standards for ARDS. Now, the various societies have actually made a lot of recommendations, like your Intensive Care Society, UK, FICM, and the French Intensive Care Society, the American Intensive Care Society, and the WHO guidelines of COVID-19 ARDS. So lung protective ventilation is recommended in all of them, as you can see. Prone positioning is recommended in all of them in moderately severe ARDS, as you can see. So this is just confirming that, all these societies are agreeing and they are in consensus with something. High PEEP is recommended in moderate to severe ARDS. Driving pressure, no recommendations have been made, but driving pressure should be used and less than 15 driving pressure will definitely reduce your incidence of ventilator-associated lung injury. Spontaneous ventilation, there was no recommendation being made. Recruitment maneuver, no recommendations being made. I skipped high frequency oscillatory ventilation because there was already so much to talk about and we don't use this. So no recommendation being made. ECMO, recommended in severe ARDS, by all the societies. So especially when there is PF ratio is less than 80 and lung protective ventilation is not possible. ECOR, there is research recommendation, but in some of them, conservative fluid strategy is recommended in most of them. Neuromuscular blockage is recommended despite of your ROSE trial. Neuromuscular blockage is recommended in early to moderate to severe ARDS. Inhaled vasodilators, though there's no recommendation made, but theoretically it sounds good. Corticosteroids again recommended in according to the recovery trial in COVID-19 ARDS, and other pharmacological therapies like tocilizumab and all that have been, some recommendation have been made in COVID-19 ARDS. Thank you. I'll stop sharing. Any questions? I think it was a really long.
Yeah, hi.
Hi, Sanath.
The indication for ECMO in the last trial, I'm not able to recall the trial name. It was PF ratio of 130, right?
Yeah, so basically the ELSO recommendations is actually coming as less than 80.
Okay.
So you try lung protective ventilation strategies. This is just not one parameter. We are using the Murray score, isn't it? The bilateral chest infiltrates, the PF ratio, and the days of onset of mechanical ventilation. So within 7 days of onset, you have tried lung protective ventilation. If there is any contraindication to proning, or you have tried proning and failed proning, and there is no other contraindication to ECMO, like you can give anticoagulation, the patient is not going to die of any cancer, or there's not any irreversible indication for ECMO, then you can definitely consider ECMO. And in Indian scenario, of course, you have to consider about the geographical availability also, and cost-wise availability also of ECMO. So ECMO does work well if instituted within the first 7 days of mechanical ventilation, because after that, what happens that there's a lot of lung injury and
the seizure trial. Yeah.
yes, yeah. So steroids in ARDS is a question from Rupesh. So Rupesh, if we go through the recovery trial, which was actually done in COVID-19 ARDS, so they have actually shown that the use of steroids in ARDS, that is 6 ml of 6 mg of dexamethasone, did show a 10-day reduced mortality in hospitalized patients who required oxygen or who required any respiratory support. So we have some evidence from the recovery trial. So early use of low-dose dexamethasone is recommended, especially if the patient, mainly when the patient is on any sort of respiratory support or oxygen therapy. I think we can end the class if there is no further questions. Thank you, everyone. Thank you for joining. If there is any request to take any further class on ARDS, any particular mode of ventilation or something in further detail to help, do let me know. Thanks, guys. Have a good day.